For now, today we will be telling you the appliance of the enzymes, enzymology. Why do we even need to know the enzymes? Okay, what is the clinical aspects of the enzyme? There are many enzymes. Some are cardio-specific, some are liver-specific, some are pancreas-specific. Okay, depending upon that, we can come to a conclusion which kind of disease it can be. First of all, I'll be giving a case of something related to the heart. Okay, it's a very common case. Clinically, it's a very important case because when you people will be in final year, whether it's medicine, whether it's pediatric, doesn't matter, somewhere or other they will be asking you from this topic. It's a very well-known topic. In normal layman language, we call it as a heart attack. Okay, but medical terminology is MI, myocardial infarction. Okay, what do you understand by the word infarction? What happens? Stoppage of what?
Flow of blood to the heart.
Flow of blood to the heart. Now there is two types of blood flow. One, that the heart is pumping. Is that pump is blocked or something? The supply to the heart is blocked. Supply to the heart is blocked. Okay. Now there are some major arteries which is supplying the heart. LCA, left circumflex artery. RCA, right circumflex artery. Names you don't have to remember right now because that will be taught to you in your anatomy classes. Okay, but if you want me to mention, I can mention. First is LCA, left circumflex artery. Another one is the right circumflex artery. From the LCA there is LMCA, left main circumflex artery, and then left anterior descending artery, and that goes behind, and that is the posterior descending artery. Okay, these are the main arteries. Other than that, there are marginal branches and all. Everything is there, and in detail, it's better to learn from anatomy only. Okay, when the time comes, you will be taught with all the anatomy because that you have to know. Can't avoid it, can't skip it. Okay. Now what happens is, in general, this is heart. Okay, just bear with the drawing. It's a rough image. This is left atrium, right atrium, left ventricle, right ventricle, and there is a septum. Okay, over here this is left coronary artery, this is right coronary artery, and over here this is the descending branch, left anterior descending, and same where this portion in the posteriorly, this dotted part portion is the posterior descending branch, which comes and reunites with this one. This is the anastomosis. Okay, of both the arteries. Sometimes it can go posteriorly, sometimes that can come little anteriorly. This is an anatomical variant that you can see in multiple patients. Okay, every patient will not have the same type of blood supply. They can have more or less, little bit of difference can be there. But yeah, these three main arteries will be there. So what happens in any one of the arteries, if there is any blockage, let's say this is the artery. Okay, this is the artery and this is where the block is. Okay, let's say this is the artery coming and this is how it is going down. This is the artery coming and this is how it is going down. Okay, and over here there is a blockage. Okay, because of the blockage, now the blood will come up to this much and after that it cannot come down. Okay, or let's say over here there is a blockage, the blood will come here and after that it cannot come down. Okay, now what happens if the blood is not coming down through here? This portion of the heart which is supplied by this artery, this portion of the heart which is supplied by this artery will not get supplied. Okay, and later on these tissues will start dying. Okay, that is what is known as the ischemia. First of all, ischemia means this block, that we can say infarction as well. And second, when it starts dying, that is what we call as necrosis in the medical terms. Okay, necrosis means getting dead and ischemia means the supply has been blocked, blood supply has been blocked. Okay, we can call it, that's why myocardial infarction or ischemia, myocardial ischemia. Okay, that's all. That is what is in general MI. For now, this much you have to understand what is MI. Okay, so whenever a patient is having this kind of block, they will present with certain types of specific symptoms. What could be the symptoms? First of all, there will be chest pain localized to the left side of the heart. Okay, so one is chest pain. Okay, this is one symptom the patient will say. Now the pain can be congestive and can be heaviness of the chest. Not necessarily all the time it will be a pricking pain or it will be a stabbing pain. It can be heaviness. Patient might come and tell you, sir, I am feeling like some 20 kg weight is put on my chest, something like that, something heavy, and that pain can be radiating. What is now radiating? Radiating means, let's say you are having pain over here, but you can feel it over here. So somewhere else you can feel the pain. So that is what is known as the radiation of the pain. Okay, source is somewhere, but felt somewhere else because of the same dermatome. Dermatome is the portion of that area which is supplied by the same nerve. Okay, same nerve supply. That is why you can feel the pain. Now, what are the common radiating zones for the myocardial infarction? One is the shoulder, back can be one, and the whole left arm. Okay, these are the common places where the pain can radiate. Okay, these are common things that you have to remember. One is chest pain, it can be heaviness of the pain as well, and it can radiate to multiple places. It can be shoulder, it can be back, or it can be the whole left arm. Okay, now whenever the patient is having this MI, there are certain enzymes which increases in our body. The list of the enzymes that you have to know. List of the enzymes are, one is myoglobin. Okay, why it happens? Because of the breakdown of the muscles. Because if the blood supply is not coming to the muscle, what is happening? Blood brings what? Nutrition, right? So if the blood is not going there, that means the muscles are not getting proper nutrition. If the muscles are not getting nutrition, means they cannot produce ATP, they will not get the energy, they will not be functioning. Fine, so they will start dying, and in that process they release this myoglobin. So first one to increase in our body as soon as the MI happens is the myoglobin. This first increases. Okay, the first one to rise. And there are many more like AST, LDH, CK. Among the CK there are multiple CK. CPK means creatinine phosphokinase. Okay, it has three things. One is MM, one is MB, another is the BB. Now the cardio-specific one is the MB type, CKMB. Okay, the CKMB also increases. Just because CKMB increases, CPK total will also increase, but these two are not cardio-specific. MM and BB are not cardio-specific. MM is mostly found in the skeletal muscle, BB is found in the brains, cerebral system. So MB is specific for cardiac. So that's why this increases more. This is the first one to increase. Okay, this is the first one to increase. MB increases, and there are two more things, that is troponin T and troponin I. These are non-enzymatic. Okay, these all are enzymatic, these are non-enzymatic. Among the non-enzymatic, troponin T and troponin I both increases, but there is a catch that troponin I is cardio-specific. Okay, now what do I mean by cardio-specific? Cardio-specific means if troponin I is increasing, that highly suggests that it is MI only. But troponin T can increase in other conditions as well. Somebody who is having kidney failures, in those patients also you can get troponin T high. Okay, so troponin T will increase. It will not. It is not that it will not increase, but this is not cardio-specific. So if you are getting a high troponin T, you cannot rule out that it is because of renal disease or it is because of MI. It can be any of it. Can be because of any other reason as well. There are multiple reasons. Okay, so troponin T is not cardio-specific, but troponin I, if it is increased, that highly suggests 99% it is an MI only. Okay, that means it is cardio-specific. Same CKMB is also cardio-specific. These two are cardio-specific. Myoglobin is the first one to increase, and the last one to increase is the LDH. This is the last one to increase. Okay, this is the last one to increase. Now at what time you can get the troponin I and all this increasing? Okay, myoglobin can increase within 3 to 4 hours. Within 3 to 4 hours it will start increasing, whereas troponin I will start increasing by 5 to 6 hours. Okay, troponin I, CKMB both increased by 5 to 6 hours. As soon as the MI starts, this can start increasing by 5 to 6 hours. At least you can see the level and you can understand it is increasing. Okay, now when it becomes the highest level in the circulation at around 20 to 24 hours duration from the episode, from the MI episode, within 20 to 24 hours it becomes the maximum level of troponin I. Okay, fine. Now what happens? There are certain enzymes as well. Okay, first of all we have understood what is MI. MI means there is a thrombus. We can say thrombus, we can say embolus, which is blocking the circulation. Because of that the symptoms are precipitating. Now in our general knowledge, if we remove the thrombus, then the treatment is done, circulation is retained, and the heart will start functioning. Now there is a thing called golden period, golden hours. Okay, like within this much period you have to remove the thrombus. Okay, there is a thing called golden hour. Within this much period you have to remove the thrombus. If you remove the thrombus, that means the circulation, basically you have to do what? You have to retain back the circulation. If you don't retain back the circulation, then the muscle will ultimately die, and if the muscle dies you cannot regain it back, it is dead for. Okay, now what happens in case of cardiac muscle? It will in case of skeletal muscle, let's say our skeletal muscle became dead, it will undergo necrosis, it will get infected, and after that you have to amputate it. In case of heart, it is not like that. It is not getting any infection source, so it is getting dead and that portion is not functioning. Let's say this is an heart, it is functioning like this, okay, and the lower portion is got infarcted. Now what happens? This portion will not function anymore, so the heart will pump like this. Okay, the lower portion is not moving anymore, so the amount of ejection that the heart was doing, now it is not doing anymore, so the ejection fraction also decreases, heart's functionality also decreases, results in what? Heart failure. That is a chronic term if you are not treating the patient. But there is a catch: if the block is in major arteries like LMCA, the main left coronary artery, if the block is there, then there is a high chance of mortality. The patient might die only, because it will not be able to continue the circulation and ultimately the patient will die. Okay, if there is when you will go to medicine, there are many divisions of identifying an MI. How to identify an MI? The first thing that we have to do is an ECG. Now I cannot tell you ECG because obviously this is not a first year thing. You have to understand everything first, physiology first, voltage first, action potential first, then only I can go to ECG. Other than that, ECG is not possible for me to teach you also. So ECG is one thing, just so you know that ECG is the first thing that we do whenever we see this kind of patients. Fine. Once we see the ECG, there are certain changes, that is, we call that in the medical term as the STT changes. ST elevation should be there. You don't have to remember all this, just for your knowledge I am telling you. ST elevation should be there. If we see ST elevation, we suspect that probably the patient is having MI. Okay, if there is a significant change, then we start with the medicines already as soon as possible. Now there is one thing we can do, echo as well, echocardiography that we say. Echocardiography to confirm our diagnosis. Whatever we are suspecting with the ECG, we confirm it with the echocardiography. Then we come to the conclusion. And these are the biochemical tests that we send. Okay, if we find these tests samples raised, then we can confirm. Now most of the time, 90% of the times, we depend on the ECG and echo only at first, because that shows the changes. But sometimes what happens is, like somebody who is complaining of pain, okay, that is just the initial phase, the developing phase of the disease. That time, you might not find these changes in the ECG, neither in the echo. In echo you can find like some wall motion that we say in the medical term, like wall motion is less. If the wall motion is less, means what? That wall is not performing properly, that it should have worked. Okay, so that means that something is wrong, but you cannot confirm it yet. So that time you can do this kind of tests and you can see the result within 4 to 6 hours. You will get the result and you can see the result whether it is raised or not. If it is raised, that means it is MI. It is developing, did not develop yet. Now what happens is, like let's say this block is there. Now I have given you example of complete blockage, 100% block. Now let's say the artery is this much and the block is only this much. Okay, it's like a 70% blockage. Okay, rest of the 30% is functioning. So some bit of blood is coming through here, but this is not adequate. 30% blood coming through, 30% opening is there. That means it's a narrow opening, and that much is not enough for the heart to function properly. So that time also you will get all these spasmodic pains and all. Okay, so the patient is symptomatic of MI, but the block is not adequate. That is why the ECG changes and the echo changes are also not significant, because the portion of the heart is still working, little less, but still working. So that time if you do this kind of tests, you can get the result and you can initially identify the case. Then you can start the treatment. Okay, now just a short note, in modern days, anybody has any idea what is angiography, angioplasty, something like that?
Or the terms like pipe.
Yeah, I'll tell. Stent, yeah, something like that. You have heard little bit of words here and there. Now let me just give you a short story so that you get a clear idea. This will not be asked to you in your first year, first of all, just to have a clear idea. Angiography is what we put a catheter through the radial artery. It goes through the arteries, goes through the axillary artery, brachial artery, then ultimately goes to the heart directly, the cardiac arteries. Over there we push some dye. Okay, push some dye. Dye means what? Color. Yeah. Now we cannot see the heart or the vessels through X-ray, right? But if we put some dye in the arteries, that will becomes radio opaque, and that time we can see it. So under the C-arm is an orthopedic surgery में हम लोग use करते हैं. Whenever you will go to the OTs, that time you can see C-arm is a thing. Under the C-arm we give some X-ray radiation, and we can see the which arteries are how much dilated. Now let's say this is the arteries pathways, okay, major arteries are coming like this. Now you are pushing the dye over here, and you can see that this artery is this much dilated, this artery is this much dilated, this artery is this much dilated. One artery over here, this much narrowing is there, okay, and then it is somewhere like this. So this is your portion where it is infarcted. Okay, this is where the clot is there. Because of that, the dye is going this much. You can see only the dye, right? You cannot see the blockage. So the artery should have been like this, okay, but it is this much narrowed. So that means there is a blockage. So that is what is angiography. We see how much block is there. If we see the blockage, there is a period within 24 hours we can go for angioplasty, that is primary angioplasty. Okay, angioplasty में हम लोग क्या करते हैं, बेसिकली सेम चीज़, यहाँ पे जो ब्लॉक है, जो क्लॉट है, उसको डिजॉल्व करने की कोशिश करते हैं और वहाँ पे एक स्टेंट डाल देते हैं. स्टेंट इज व्हाट, दिस इज जस्ट लाइक ए पाइप लाइक थिंग. ओके, वी पुट इट ओवर हियर एंड प्लेस द पाइप लाइक दिस. Done, so that it do not collapse again, and these stents, modern stents, are already pre-medicated. This will help not so that later on any other thrombus should not form over here. Okay, got it? So that is angiography, angioplasty in general. Not necessary for you, nobody is going to ask, but at least I don't want anybody of your relatives or anybody should undergo all these things. But yeah, we never know, because our sedentary lifestyle is so bad nowadays. Before we used to have MI patient, that is the mean age was 45, 50, something like that. But nowadays we are even getting the cases at 25, 30 years of age. So there is a 20 years of age gap is coming nowadays. Patients are coming with MI, young patients. Why? Because alcoholism, first of all. Second, smoking, the worst thing. Any cardiologist you go, any cardiologist you ask, what is the worst thing and what will be your one suggestion to your patients not to do is smoking. Never ever. Because smoking increases the chances of precipitating MI more than many folds, by many folds. Okay, so that is the one thing, the first and foremost thing you should tell. If any of your known people are smoking, tell them to stop it as soon as possible. It might be difficult, but for the betterment of their health, that should be advised. Okay, first of all. Then what happens, these stents are already pre-medicated, and this helps so that the later on this should not form any other embolus over here. Okay, that is in short is MI. Now what you have to remember is, there is a case that I have given to you people. Okay, see from here, this kind of cases can be given to you in your question and can be asked like identify the case. Okay, simple case, nobody will ask you difficult cases in first year. Okay, so simple cases can be asked. So see the keywords. First of all, a 56-year-old chronic smoker. So one keyword you got, chronic smoker. Okay, so smoking is there for how much time? For past 30 years, which is a very significant time duration. Okay, 30 years means lots and lots of tar is there. Lots and lots of tar, tobacco. The patient is having so much of tobacco that it can precipitate MI. 1 point. Now comes lawyer by profession. That means stressful life. That is one important. Okay, stress can precipitate MI. If somebody is having this kind of 70% block, okay, let's say somebody is having 70% block and the patient is asymptomatic. Okay, patient heart is pumping, patient is not having chest pain, but he is having that 70% of block. All of a sudden he got a bad news. The body undergoes stress, releases hormones which can cause vasospasm. Vasospasm means vessel becomes more narrowed. Vasodilatation means dilated, vasospasm means more narrowed. Already 70% dilatation is there. More spasm means what? Complete blockage. That can precipitate the MI. Okay, so stress can precipitate MI. One thing. There is one thing called angina, prinzmetal angina. Those are separate things. When you will go to medical classes, medicine subject proper, that time you will understand. I am not going into that deep right now. Okay, now pain type. What are the type of the pain? Heaviness of chest. Okay, heaviness of chest, and it with pain on the left upper limb. That means it is radiating to the left upper limb. Radiation is positive. Radiation of pain is positive. Okay, where? Significant in the left upper limb. Okay, significant. And he is a known case of hypertension. Another history. Now hypertension can be because of many reasons, but the most two important reason, one is the cardiac reason that can lead to hypertension, another one is the kidney. If the kidney arteries are already stenosed, kidney arteries are narrowed, that can lead to hypertension. Okay, so Hypertension history, if the patient is having hypertension history, that complicates the case even more. There is a more chance, the more the complication, systemic diseases, the more the systemic disease you have, the more chances of you developing this MI. Now luckily this patient is not having diabetes, but if the patient is having diabetes, even more complication you can expect, you can think of, okay? Because even if a patient is having non-diabetic, you can undergo any operation anytime. But if the patient is having diabetes and the sugar levels are not controlled properly, you cannot immediately go for any operation. You cannot go for any procedure immediately, even though you have to eventually, but that will not be good for the patient. The patient can get infection easily, very easily. Okay, when you will come to micro, that time you will understand why diabetes is so bad. Because if your blood contains sugar, the sugar is a very good nutrient media for the organisms to grow. If in my blood, if a organism grows in X speed, in that patient the organism will grow in 5x speed. That much rapid the infection will spread. So that is why diabetes is bad. Okay, so main motto of the topic is, if there is any history of systemic illnesses, the complications of the disease will increase by multiple folds. Okay, so HT and T2DM, these are risk factors for the disease. Fine. Now what are the lab findings? I have already mentioned you the enzymes. See, trop-T, these are the normal range, and this is the value that you got in the patient. Okay, now these things you don't have to buy hard. This is just a case presentation. Okay, these are also normal ranges. Nobody is going to ask you what is the normal range of trop-I, what is the normal range of trop-T. In first year at least nobody will ask you. Final year they might ask you, but not now. For now you have to just remember the names of the enzymes that can increase, okay, and what are the cardio-specific enzymes specifically. So what are the enzymes? AST is there, LDH is there, you cannot see it though over there, that is LDH, okay, it got overlapped, and CPK-MB, CPK total. Why CPK-MB? Because it is cardio-specific. CPK total because if the MB is increasing means total will also increase, simple thing. Trop-I, trop-T both will increase, but trop-I is more specific, fine. Now ECG will show some ST elevation. That's all. Nobody is going to ask you about ECG, but ECG will show some ST elevation. When you will go to medicine, you will learn everything in detail about ECG. Somewhere or other, you will get little bit of idea in the physiology itself. Okay, when you will be, they will be teaching you action potential, cardiac action potential, and that will be correlated with the ECG. That time you will get little bit of idea of what is ECG, and that time you can understand what is ST elevation. Okay, right now you will not understand anything what is ST elevation. Now angiography will show more than 80% of block. That I said that you will put the catheter, see the cardiac vessels, how much block is there. If it is more than 80%, we have to go for angioplasty. If it is less than 80%, somewhere or other we can choose about going for medical management or going for surgical management. It depends to us. Okay, but if it is more than 80%, it is highly suggestive to go for angioplasty only, so that you can open it up and put a stent later on, so that it does not form a block over there. Now there are some medical management which I am telling. Angioplasty is the surgical management. Okay, now medical management is what? From biochemical point of view, there are two enzymes. There are two enzymes again which is helpful in breaking this embolus, breaking this thrombus. Okay, what are the enzymes? One is streptokinase, another one is the urokinase. Okay, these two are the enzymes. Okay, remember these two are the enzymes. There are many other medicines like retiplase, altiplase, tenecteplase. These are drugs, okay, that you will be taught in pharmacology. Those drugs can also be used to block the clot, but these two are the enzymes that can help you breaking the clot. These are little costly. Those drugs are also costly. These are all costly drugs. Okay, these drugs can break the clot. Now there is a catch. You cannot use these kind of drugs after 6 to 8 hours. Okay, after 6 to 8 hours you should not use this. Somewhere or other sometime people use it, but you should not. Why you should not? Because well, let's say over there is a block, 100% block, and the patient comes to you after 6 to 8 hours or 10 hours of the initiation of the pain, and that time you are giving this thing, and this will not be able to dissolve the block completely. Why? Let's say this is a blood vessel, okay, and this is where the block is initially. Okay, let's say this is the block which is there completely. Now if the patient is coming initially, you give the medicine, it will be dissolved. There is a chance it might not get dissolved also, not necessarily that you give the medicine and it will get dissolved only. It might not get. Okay, if it's a big one, it will not get dissolved. If it is a small one, it will get dissolved. Now after 6 to 8 hours, the bloods are circulating, but blood cannot come through here. Blood is coming over here, going back. Some bit of the blood particles will stack up over here. Some bit of particle will stack up. over here and keep on increasing the embolus. So if the embolus is much more larger after 6 to 8 hours, there is no point of giving streptokinase, urokinase. It will not be able to break it. That is why we don't use it. Some people use it, even though some practitioners use it, but it is not advised. There is no point of doing it. Why no point? Because these also have a side effect. Side effect is what? This makes the blood very thin, okay, and the bleeding time increases. Now what do I indicate by bleeding time increases? Let's say somebody has an operation, post-op patient, okay, surgery has been done in the patient has an active wound. On the third day of the surgery, patient develops an MI. Okay, now if you give streptokinase or urokinase, something like this kind of medicine, or retiflase or altiplase, what will happen? From the active wound side, it will start bleeding. The blood becomes thin, and from any leakage it gets, from there the blood starts coming out. And it becomes very difficult to control as well. Okay, there are many more complications like hemorrhagic stroke can happen. I am not going into that because you won't understand right now. Okay, inside the head, in the brain, there starts bleeding because the blood vessel becomes fragile and the blood comes out. Okay, and that is what these are the complications. So if the patient has already crossed the golden time, don't go for it. Up to 24 hours you can go for angioplasty. In some setups you can go for after 24 hours as well, but after 24 hours if you are going for angioplasty, there can be complication. So everything has a reason why we are not doing it. So up to 24 hours only we are doing the primary angioplasty, otherwise we don't do that much. Later on you can do it, but there is catch. You have to maintain some precautions. The patient can complicate because the thrombus that you thinking to take out, it can get dislodged from here and can go somewhere else and block it. It can go to the brain and block it. Stroke. The same concept which is happening in the heart, we are calling it as MI. The same thing, whenever the cerebral vessels are getting blocked, that is what we are calling it stroke. Stroke can be of two types. One can be this clot induced, another one is the rupture. If the blood vessels are bleeding, okay, that is a hemorrhagic stroke. That's all. That much is necessary for now. Now, over here there is a chart given. Okay, now in this chart what we have mentioned, see the first one to rise is these are the multiple folds. Okay, let's say x is the normal value of a test. Okay, and these are the multiple folds, 1x, 2x, 3x, 4x, 5x, 6x, 7x times. How much fold the level will increase in the blood, and this is the duration of hours. Each small quadrant will equal as 4 hours. So 4, 8, 6, 12, 16, 20 hours, like that, 24, 28, 32, 36, 40 hours, like that. Okay, so the first one to rise is the myoglobin. These are the one thing you have to remember. Myoglobin is the first one to rise. The last one to rise is the LDH. The last one is the LDH to rise. Fine. Now these are the two lines that you have to remember. First one to rise, last one to rise. खत्म हो गया चार्ट से, दो चीज सीखा. और बीच में क्या क्या बढ़ रहा है? CKMB बढ़ रहा है, टोटल CK बढ़ रहा है, almost close to same time. Even tropi is also similar to close by same time only, 20 to 24 hours के बीच में ये बढ़ जाता है. Fine. That is the highest peak point you are getting. Now this CKMB and tropi, these are cardio-specific. These are the simple keywords you have to remember. Which are the biochemical enzymes that is related to MI, which are cardio-specific, which one is increasing fast, which one is increasing last, and by what time you are getting the peak of troponin and CK. That is by 20 to 24 hours you are getting the highest peak. Fine? Understandable? Okay. This much only, nothing more. Now, there are certain questions. Diagnose the case and explain why. This can be asked like this. In your exam, if they will give a clinical case like this, and then they will ask you, diagnose the case and explain why. Diagnose the case, probably it's a case of myocardial infarction. Why? Patient is having history of smoking, stressful life, heaviness in the chest, that is the pain type. The type of the pain suggestive of MI. Okay? Patient, yeah, and history of hypertension and type 2 diabetes mellitus. And these are the clinical history. And the biochemical history, see, all of these are raised. Everything is increased. All the enzymes that is significant of MI, everything is raised. So, by depending upon the clinical symptoms as well as the biochemical reports or the, you can say lab reports, enzymes are raised, because of which I can come to a conclusion the patient is having MI. Okay, fine. Now, what is angina? the pain that I am telling in case of chest pain, the heaviness or the spasmodic pain the patient is having, and it is radiating to the shoulder tip or the left upper arm or the back. This is known as angina. In proper word, we call it angina pectoris. Can you tell me why it is pectoris? Pectoralis muscles are there, so we feel like these muscles are getting pain in the muscle. Now it can be pectoralis major, it can be pectoralis minor, so that is why we call it as a term as angina pectoris. Okay, that's all. Now what are the various enzymes and non-enzymatic markers to diagnose MI? Now these all are enzymes: myoglobin, tropi, these are non-enzymes. Okay, 3 enzymes, 3 non-enzymes. Okay, now which troponin is more specific? Troponin I. Troponin I is more specific. Fine. What name the enzyme that can be useful in treating such cases? Streptokinase, urokinase. These are the enzymes. Again, I am telling you, these are the enzymes. Okay, these are the enzymes that is helpful in the treating of MI. And what are the risk factors of MI? I have already told you: chronic smoker, stressful life, heaviness of the chest pain. This is not a risk factor though, this is the type of the pain. Hypertension, diabetes. Now sedentary lifestyle. What do you mean by sedentary lifestyle? Sedentary lifestyle means smoking, drinking, doing party all the time, having junk foods all the time, not sticking to a base staple diet. Okay, no exercise. These are all coming into sedentary lifestyle. Basically, we are the people who is leading the sedentary lifestyle. That is why the age gap is coming so low. Before, people used to work in the fields. They used to have a good diet. Then they were not used to having smoking or alcohol every other day. Nowadays, people are so much influenced by the Western culture. They are taking up all these bad habits only, and that is why the age is also coming down. The episodes of MI is all coming short by short. Somebody know KK singer? How much was his age? Such a talented person, but stressful life. Okay, and I don't know about the life habits, but stressful life all the time. Okay, so because of all these things, this MI can precipitate at an early age. Okay, that's all. So these are the risk factors. And another word is dyslipidemia. Can anybody tell me what is dyslipidemia means? Just try to understand. Lipid, something to do with the lipid.
Lipid in the blood.
No. Dyslipidemia means disorganized, disarranged. Okay, so we do the lipid profile in a patient. Okay, we do the lipid profile. We can get what? Triglyceride level, HDL, okay, LDL and VLDL. Okay, these are all the and cholesterols. Okay, now when these are high, okay, when these are high, these are dearranged, we call it as dyslipidemia. How this is bad? When these are dearranged, these will make more of this thrombus. This will help form more of the thrombus, which can precipitate MI. That is why dyslipidemia is one thing that is a risk factor for this condition. Now, if there is an increased age, obviously there is more chance. That is nothing to mention separately. So that's all. Now, in general, over here the explanations are there. The clinical presentation and the biochemical findings suggest that the patient is suffering from myocardial infarction. We have already seen what are the clinical features, what are the biochemical findings that can be. Now, in this condition, the cardiac myocytes undergo necrosis due to lack of blood circulation. What happens in this MI? Now, pain is compressive in type, and the precordial region. Precordial region is this region. Okay, in this region, left side of the upper, left subclavian region, as well as in the left clavicular region. From these to the whole upper arm and all. Okay. Now, precordial region to the chest could be radiating to neck, shoulder, and the left arm. These are the common site where it can radiate. Okay. Now, anybody has any idea about dextrocardia? What is dextrocardia? Out of the box question hai.
Instead of left, it's right.
The heart is located in the right side. Okay. Anybody has seen the movie Luck? At the end, he don't die because why? He is having the heart in the right side. Okay. It's a very rare condition. Just thought of giving you the idea. Dextro means right. Cardia means right-sided heart. Okay. That's all. Now, various enzymes which are used to assessment of the MI are CPK total. CPK total includes CPK BB, MB, and MM. Okay. All these three. But MB is the one which is specific. And two other enzymes are there, AST and LDH. Okay, so these three are the enzymes, and non-enzymes are the tropi, and the myoglobin. These are non-enzymatic markers. Okay, CPK enzymatic specific is the CPKMB. It's an isoenzyme of the creatinine kinase. By the way, CPK full form is creatinine phosphokinase. That is what is written over here, creatinine kinase, and is most abundant in heart. Why CPKMB is so specific? Because this is present in heart in most abundant way. excessive amount of these are present. So whenever the cardiac myocytes are getting damaged, these are getting released into the circulation, okay, and whenever these are coming into the circulation, you are getting higher level of these enzymes, and that you can estimate and you can come to the conclusion is something is happening to the heart, okay. That's all. Now these are the one thing that can be assessed to rule in or rule out. Rule in means if it is high means ruling in of MI, and if these are low means ruling out of MI. Okay, ruling in and ruling out means diagnosing it and taking it out of the box, out of the concept. Like somebody is telling you about chest pain, you check the CPK-MB and it is low. That means it is not, at least it is not MI, that is ruling out MI. And somebody complaining of chest pain, you are checking the CPK-MB, it is excessively high, multiple folds high, you are ruling in MI. That is ruling in and ruling out, okay. Okay, now non-enzymatic markers of MI are troponin T, troponin I and myoglobin. Myoglobin is the first one to rise, troponin I is the specific of cardiac issue. Now troponin I is more specific than troponin T, and there are few enzymes which can be used in the treatment of MI as a thrombolytic agent. What is thrombolytic? Thrombus is there to break the thrombus, that is a thrombolytic agent. Thrombolytic agents are the streptokinase, urokinase, something like that, okay. And risk factors of MI is smoking, we have told, dyslipidemia discussed, DM discussed, HTN discussed, sedentary lifestyle discussed, male gender. Females are less prone, males are more prone, but nowadays females are also competing highly with us because they are also leading the more sedentary lifestyle like us, okay. So that is why, but in generally male genders are seen with more episodes of MI. Advanced age, whenever the age is increasing, there is increased chances of, with age more of this dyslipidemia factor comes in effect. All this lipid profile, if there is deranged lipid profile, this can lead to a formation of thrombus that can lead to MI ultimately. That's all. These are the take home messages for you. First of all, identify the case. Why you are identifying the case like that? There is clinical feature as well as the biochemical features. Everything you are suggesting to the MI. Then which are the enzymes that is increasing in MI? Which are cardio-specific? Which are not cardio-specific? Which one is coming at first? Which one is coming at last? What are the risk factors? And which enzymes you can use for the treatment? That's all. Easy to remember? Fine. One case is over. Now the second case. So these are the practical appliance of the enzymology, because these are enzymes. Why we should learn enzymes? To diagnose a case. Okay, to diagnose a case we are learning these enzymes. These enzymes are specific for particular disease, particular case. Okay, like AST, LDH can be raised in other conditions as well. But CKMB will not be raised in other conditions. These will be raised in case of MI only. Trop-T can be raised in other conditions as well. But Trop-I will be raised in case of MI only. Okay, so that's how these are helpful to pinpoint a disease, pinpoint a particular case, pinpoint a particular diagnosis. Okay, that's all. Now coming to the second case. What is the second case? A 45-year-old male presents with intense pain in the epigastric region. Now your anatomy is not covered till abdomen, I know. So let me give a rough idea what are the regions so that you can understand. Okay. First of all, look here. When the anatomy people will teach you, that time you people should be able to tell all these things. They will be surprised that yeah, you know already. Okay. Okay. Let's say this is umbilicus. Okay. And this is the xiphisternum. Xiphisternum, you know, sternum terminal point, that is a xiphoid process. So this xiphisternum, this is the end point, is the xiphoid process. These are the lower border of the ribs. Okay. Over here we are taking an imaginary line. Okay. This is known as the transpyloric line. Why transpyloric? What is the meaning of pylorus? Pylorus means stomach. Okay, so we are taking an imaginary line at the level of stomach. That is why this is known as a transpyloric line. It's an imaginary line, not taking it really. There is no line in real, but it's an imaginary line. Now there is another line, that is the transtubercular line. Why tubercular? There is a tubercle. What are those tubercles? These two tubercles. Spinous processes, anterior-superior iliac spine. Okay, these are the two tubercles. So connect the two tubercle and make an imaginary line. That is why this is a transtubercular line. These are two horizontal lines. We need two vertical lines as well. From where? The mid of the clavicle. This is clavicle, midpoint of the clavicle. From the midpoint of the clavicle, you take an imaginary line. From this side also, midpoint of the clavicle, you take an imaginary line. Fine. Now these four lines, these are the mid clavicular line. Okay. Now these 4 lines have separated your whole abdomen into 9 segments. Okay, 1, 2, 3, 4, 5, 6, 7, 8 and 9. Fine. Now try to understand. This area is known as epigastrium. Okay, स्टमक से ऊपर है एपिगैस्ट्रियम. ठीक है. दिस वन इज लेफ्ट hypochondrium. Why hypochondrium? Do not by heart names. Try to break the words and understand. Chondrium means, chondro means rib. Okay, cartilage or ribs you can say. So hypochondrium means just under the rib. Okay, so this portion is just under the rib. That is why left sided hypochondrium. खत्म. Right side का भी same आ जाएगा. Right hypochondrium. Easy. Okay, now this is what? Umbilicus. So this is umbilical region. Fine. In this region, which spine do we have? This is cervical. This is cervical. Then the chest is the thoracic. After thoracic, lumbar. So this is lumbar vertebra region. So this is left lumbar region, and this is right lumbar region. Okay, done. Now this one is, what is this? This bone, this big bone in the hip.
Pelvis.
Pelvis. Which bone is there? Some crest is there. Iliac crest. So this is left iliac region. This is the right iliac region. Easy to remember. And this one is below the stomach. So this is hypogastrium. Okay, above epigastrium, below hypogastrium. These two are according to the rib cage. Hypochondrium. These are lumbar, and these are iliac. खत्म. ये 9 regions है. Now, sorry. Now what the patient is saying, there is an intense pain in the epigastric region, means this region. This region there is pain. And periumbilical region means around this region. These two are the regions where the patient is complaining of pain. Okay, and the pain is radiating to back and is associated with vomiting. Radiating to back means the pain is happening here, but you can feel it in the back as well. Okay, so pain is there. The histories are, which is significant, pain is there in the epigastric region. That is very significant. Okay, epigastric region pain can be because of, one is gastritis, another one is pancreatitis. Okay, now we will be going towards it one by one. So pain is there in the epigastric region plus periumbilical region. It can be there, might not be there. Not necessary that every time you will have a periumbilical pain. It can be there, it might not be there. But epigastric region pain, definitely it should be there. Okay, now he had associated with vomiting and 2 episodes of vomiting. 2 episodes means in the medical term we don't say 2 times, 3 times, we say how many episodes of vomiting. Okay, fine. Now while coming to the hospital, he has low grade of fever. Fever is not a disease, it's a sign. It's telling you something is wrong with the patient's body, somewhere or other there is inflammation. Because of the inflammation the patient is getting fever. Okay, so the inflammation means some organ is getting inflamed, something or other is getting inflamed. Okay, so that is the significance of fever. And here is a chronic alcoholic. Now this is a typical history, alcoholism history. The most common cause of getting pancreatitis. There are many other causes of getting pancreatitis, but the most common cause of getting pancreatitis is alcohol intake. Okay, so alcohol history. Alcohol history is present for how much time? For 15 years. That is also significant. Okay, that's all. Now on palpation, abdomen is distended and tender. Palpation means when you are checking the abdomen, that is distended, means it is bloated. Okay, and it is tender. Whenever you are palpating, the patient complains of pain. Okay, because whenever you are palpating, deep palpating, you may be pressing on the other abdominal structures, may be pressing on the pancreas, and that is why you are getting the pain, referred pain. And the pain, because of the pain, when it gets unbearable, we start vomiting. And pancreas is the one that is releasing the enzymes for the digestion, and if the digestion will not be happening, what will happen? Bloating. That is why that abdomen is tender and patient is feeling nauseated and vomiting. Okay, and then auscultation, you can see the bowel sounds are absent because the food particles are not getting down, because the abdomen is already bloated up and the food particles are not getting down. In this time, medically we do some trials to be put some tubes through the nose and decompress the abdomen. Okay, so not going into it, you don't have to know all these things, but yeah, that is what the reason. Okay, so there is some bloating is there, gas formations are there, foods are not getting digested properly because enzymes are not coming from the pancreas. And on auscultation you can get no bowel sound. No bowel sound means bowel movement are not there. Like the food we are taking, it goes down by the process called as peristalsis. Peristalsis means the movement of the food. If the peristalsis is not there only, then the bowel sound will be absent. There is no movement at all. The kinetic movement is not there. Now there are some lab findings. In the lab findings, what did you get? That the serum amylase and the serum lipase is high. Okay. Now in case of pancreatitis, amylase and lipase both will increase. Okay, but in certain patients you can get that the amylase is not increasing significantly. Why? There is a normal range given. To call it a pancreatitis, it have to increase by 3 folds. Okay, let's say normal range is 60, so it have to be more than 180 to call it or rule in a pancreatitis. Till then you can suspect. You cannot call this is a pancreatitis, you can suspect. But if the lipase is more than 3 folds and the amylase is normal, then also it is pancreatitis, because lipase is pancreas-specific. Amylase is not specific. Amylase can occur in case of acute pancreatitis, chronic pancreatitis, pseudocyst, renal issue, opiate poisoning, anywhere. All these conditions you can get amylase high. Okay, so amylase is not pancreas-specific. Lipase is pancreas-specific. So if a patient is having 3 folds increase in the lipase, whereas the amylase is looking normal, still the patient is having pancreatitis only. Okay, got it? Any doubts till now? Okay, so the fever, why? Fever was why? Because the pancreas is already inflamed, and because of that inflammation, the inflammatory markers are released in the circulation, which is causing the fever. Okay, the cytokines, when you will go to physiology, you will get to know what are cytokines, why it is getting released in the inflammation, what happens in the inflammation, what are the 5 signs of inflammation. Okay, these are, inflammation is a very important topic, repeatedly asked in the exam, somewhere or other in the viva or in the written or somewhere or other it will be asked, and it's a very important topic. Don't miss inflammation at all. Okay, so because of the inflammation of the pancreas, we are getting all these symptoms, and inflammation of the pancreas is known as pancreatitis. Itis means inflammation and pancreatitis means pancreas inflammation. Now these are certain questions. Now what is the diagnosis based on the clinical and the biochemical finding? Clinical finding is pain in the epigastric region, alcohol intake history, as well as bloating, periumbilical regional pain. These are clinical. Biochemical history is rise in amylase and lipase. If you go in the report, you can see it is 520, which is more than 5 times. It is 780, which is more than 10 times. Okay, so that is how these are significant, suggesting of pancreatitis. So what are the diagnosis based on the clinical and biochemical findings? We are coming to the conclusion. Now what are the criteria to diagnose acute pancreatitis? The same criteria, whatever the clinical criteria that I have mentioned, these are the diagnosis of acute pancreatitis. Now what are the single best enzyme to diagnose pancreatitis? Lipase. These are enzymes. Okay, so that is the use of enzymology. So lipase is the best enzyme to diagnose pancreatitis. Now what is most sensitive test to detect pancreatitis in the early stage? What do we understand by this? Let's say we can do many types of tests actually to identify pancreatitis, not just these enzymes. These enzymes are the lab test. We can go for radiological findings. Radiological tests like CT scan we can do. Okay, MRI we can do. Now there is one catch. We can do MRI brain. We can do MRI abdomen, but we cannot do MRI. Okay, MRI of the pancreas system you cannot do because it's a deeper structure. You have to go for MRCP. Okay, same concept. Okay, MRCP में क्या होता है? Full form of MRCP is magnetic resonance, and I means imaging. Okay, magnetic resonance imaging, as simple as that. But in case of CP, that means pancreaticography. Okay, no need to remember the name. I'm just breaking you this word so that you understand. Cholangio means something related with the gallbladder. Cholangitis, cholecystitis, something related with the gallbladder. Okay, so that is GB. Okay, gallbladder is related, that is why cholangio. And pancreaticography means pancreas related, and graphy means imaging. Okay, so that's what. In case of MRCP, we do the imaging of gallbladder and the pancreas. That is why it is known as the MRCP, magnetic resonance cholangiopancreatography. Why GB is also important? Because of the location. See, this part is the pancreas. Okay, this is the second part of the duodenum, and this is where the gallbladder duct is also opening. Okay, this is the liver. This is also opening in the same region. That is why imaging of the gallbladder, common bile duct, hepatic duct, as well as the pancreas is important. Okay, so if there is any blockage in this area duct, this can cause pancreatitis as well. That is gallstone induced pancreatitis. Okay, and if there is any pancreatitis, that can inflame this area and the bile duct will get blocked, the bile enzymes will not come out, and that can lead to jaundice like feature as well. Okay, that's all. That is why these are important. So in case of MRCP, we are doing the imaging of the GB, gallbladder system, as well as the pancreas system. Okay, these are two imaging. Okay, now there is called as invasive and non-invasive procedure. What is invasion? First you have to understand. Let's say you are inside your house. Okay, I am going inside your boundary, means I am invading your private property, and I am staying outside your boundary, means I am doing whatever I am doing, I am outside your property. That is non-invasion. So CT and MRCP, we are not going inside your body. From outside only we are using the instrument, doing the rays and whatever it is, and we are getting the diagnosis. That is non-invasive procedure. And there is called a invasive procedure. Invasive means we are going inside your body and then we are imaging. What we are doing? One is ERCP, one is EUS, another one is something called secretin test. Okay, now what are these things? Try to understand this. I don't think so anybody will ask you. They might ask you as much as like what are the invasive tests, what are the non-invasive tests. These are non-invasive. Okay, but nothing more than that. But why I am telling you, if you know it, if you understand the reason, at least you won't have to have some difficulty to remember, because you will remember it just like a story. जैसे मैंने बता रहा हूँ ऐसे स्टोरी की तरह याद रखो, खत्म. EUS मतलब endoscopic ultrasonography. We know ultrasonography, USG. Over here also you can go for USG also. That is a external. बाहर से जेली लगा के प्रोब लगा के देख रहे हैं, खत्म. Endoscopic ultrasonography is what you are putting an endoscope through the mouth, going deeper structures, coming over here. Okay, in the duodenum, coming over here. From here you are doing the endoscopy. That is from here you are doing the sonography. That is what is the endoscopic ultrasonography, US. Okay, just like that. In case of ERCP, what you are doing? ERCP full form is the endoscopic retrograde cholangiopancreatography. Now again I will make you understand why this is like that, why the name is like that. First of all, endoscopic means something we are doing with the endoscope. Okay, we are putting the endoscope through the mouth and going up to this area in the duodenum, second part of the duodenum. What we are doing over here, normally what happens, this is the pancreatic duct. Okay, and the enzyme is coming from the pancreas to duodenum. This is the normal route. Bile duct से भी enzyme ऐसे आ रहा है. This is the normal route. So whenever we are going positive, that means we are going forward, means anterograde. Whenever we are going ulta side, that means retrograde. So retrograde means something is happening opposite. Okay, what we are doing is we are putting the endoscope here and we are injecting saline this side, opposite side. We are putting the saline this side to see the patency of the duct, if the ducts are open or closed because of stones or any other obstruction, what is there. To understand the pathology, we are putting some saline through here. So this saline is going opposite direction, that is why endoscopic retrograde. And cholangiopancreatography, why? Because whenever you are putting the saline through here, it is going through this side as well, it is going this side as well. Okay, and over here along with the saline we are pushing the dye. We are pushing the dye. As soon as we push the dye, we see in the CT scan से वो dye किधर तक जा रहा है. If there is any blockage, some stones are there or not, some stricture is there or not. So that these are the things we can see from the ERCP. Okay, so that is why the name is endoscopic retrograde cholangiopancreatography. We can understand the GB system as well as the pancreas system. Fine, understood. So we are doing it via endoscopy, means I am invading your body, going inside your body, then checking. That is why it's an invasive test. ERCP, EUS, these are all invasive tests. And then secretin test. What is their secretin test? Let's say a patient comes with a very early stage of pancreatitis. There is no pain, nothing. कभी कभी पेशेंट आता है ना, बस ऐसे ही आ गया चेक करवाने के लिए, उसको पता है वो रोज़ दारू पीता है, उसका कुछ ना कुछ ऑल्टर हो सकता है, वो ऐसे ही आ गया चेकअप करने के लिए, सर देखिए मेरा कुछ है या नहीं है. Okay, he came, you have done all the tests, but somewhere or other you are feeling like probably the patient might have pancreatitis because of the history of alcoholism, whereas all the blood reports are normal, CT scan, MRCP, everything is normal. So that time you can go for secretin test as well. What we are doing, we are putting a needle to the pancreas, taking out the sample, and then we are doing the test. And this is very specific, means if the secretin test is showing positivity, means definitely the patient is having pancreatitis. Even before the development of the radiological symptoms, you can identify the pancreatitis. But there is a catch, we don't perform this test. Why? Because if we are poking the organ which can get inflamed, there can be complication. If there is a non-development of pancreatitis, it can flare up into pancreatitis. अभी तक उसका symptom नहीं था, अभी उसका आएगा. So you have intentionally done it, unintentionally done it. अच्छा करने गए थे, बुरा कर दिया. That's why we don't perform it. We perform up to this, all these tests only. Secretin test is very specific. This is important theoretically. कि which test is most specific, most sensitive. In the earliest of the earliest phase, you can detect the case, but we don't do it. Understood? That's all. Now, that is what is written over here. What is the most sensitive test to detect the pancreatitis in the early stage? That is a secretin test. Most sensitive and most specific as well, but we don't do it. Why we don't do it? That also you haven't got it. Now, what are the common causes which are associated with acute pancreatitis? First one is the alcohol intake, then gallbladder stone induced. Okay, there are multiple other reasons like any trauma. Okay, if there is any patient any person who is driving a bike or something very rashly, and some other he underwent an accident and he got a trauma to the pancreas. Pancreas will get inflamed and will show the same sign of pancreatitis. There is one more condition which is glyceremia, मतलब triglyceride, TGL. Normal triglyceride level should be up to 150. Normal range. Those people who are having dyslipidemia can go up to 300, 400, something like that. Somebody who is not maintaining diet properly, fatty foods, junk foods, outside foods, sedentary lifestyle, they can have 300, 400 of dyslipidemia. But what if somebody is having triglyceride level more than 1000? Why it can happen? It can happen because the enzyme which is necessary to dissolve the triglyceride, that is not there only in the patient. Okay, and because of that they can develop this high level of triglyceride level, and that can also lead to pancreatitis. Okay, that's all. Now, which type of hyperlipidemia is associated with the chance of getting pancreatitis? This type of hyperlipidemia, hypertriacylglyceremia. Okay, the answers are given over there, see it. Based on the clinical presentation and the biochemical finding, the patient is having acute pancreatitis. Why? Epigastric region pain, which is radiating to the back, more than 3 times raise in the amylase lipase and or amylase. Lipase is specific, उसके साथ amylase हो चाहे ना, वो फ्री में आ रहा है. अगर आ रहा है तो भी अच्छा, ना आ रहा है तो भी अच्छा, लेकिन lipase अगर आ रहा है मतलब it's a pancreatitis. Abdominal imaging like CT, MRCP, ERCP, EUS, these all are the imagings. Okay, invasives are ERCP, EUS, non-invasive are CT, MRCP, USG. Fine. Now, single based enzyme is lipase. It is specific for pancreas and the inflammation, but amylase is not specific. Why amylase is not specific? Raised amylase level can be seen in case of acute pancreatitis, chronic pancreatitis, pancreatic pseudocyst, pancreatic cancer, renal insufficiency, burn patients, diabetic ketoacidosis, pregnancy, opiates poisoning, multiple reasons are there. So it is not specific to only pancreatitis. It can be any pathology to the pancreas, it can be other reasons as well. Now, direct invasive test to detect the pancreas. Invasive test, you understood what is invasive test. Direct invasive test to detect the pancreatic secretory function is the secretin test. The test is most sensitive and specific. It is used most sensitive and specific. Specific means if it is positive means it is pancreatitis only, and sensitive means even if little bit of enzyme rise is there, that test can detect, secretin level can detect this test. That is what is the specific. I have already mentioned before why we say some test is low sensitive, means below the threshold level if your test cannot detect the presence of the constituents you are looking for, that's a low sensitive test. Little bit, as little as possible amount is there, but still your test can detect it. That means it's a very sensitive test, highly sensitive test. That is why when we were talking about Rothera's test was a less sensitive but highly specific. Why specific? If it is positive means it is ketone bodies only. Low sensitive because if it is less than 20 milligram you cannot trace it. You can, if it is a traceable amount, you cannot detect it with the test. That is why it's a low sensitive but highly specific. But in case this is highly sensitive, highly specific, as little as possible it can detect, but we are not doing it. Okay, because we will poke the organ which is not inflamed yet, it can undergo inflammation again. That is why we don't do it. Okay, now Yeah, it is used to detect the early chronic pancreatitis when the imaging is inconclusive or normal. Imaging is inconclusive. Imaging radiologists said that we are not finding anything out. They will not write it down. They will be telling you, please correlate clinically. We are not getting something significant. You have to correlate clinically with your clinical knowledge. So that time you have to go for this kind of test, but we don't do it. Okay, so something like that. If we are having this imagings are inconclusive or imagings are showing normal only, that time you can do, because the history is significant. नॉर्मल पेशेंट जो दारू नहीं पीता है, कुछ नहीं है, कोई ट्रॉमा हिस्ट्री नहीं है, कुछ भी नहीं है, उसमें तुम जाके सिक्रेटिन टेस्ट नहीं करोगे. पेशेंट इज हैविंग हिस्ट्री बट एवरीथिंग इज कमिंग नॉर्मल, दैट टाइम यू कैन गो फॉर सिक्रेटिन टेस्ट. नाउ नॉन इन्वेसिव टेस्ट आर द USG, CT, MRCP. Fine. Invasive tests are the ERCP, EUS, secretin test. These are all invasive tests. And causes of acute pancreatitis: gallstone induced. Why? If there is a gallstone blockage, over here there is a gallstone blockage, the pancreas juice cannot come out, it can get inflamed. Okay. Now alcohol intake, one of the most common causes. Abdominal trauma, RTA, following any RTA. ERCP induced. Now ERCP induced is what? ERCP induced में क्या हो सकता है? Whenever we are doing this ERCP, we are putting the saline in the opposite direction, right? So this saline, this is a fine work by the doctor's hand. Okay, somebody who is doing ERCP, their hand is very fine. They have practiced for the fine work. Putting an endoscope and through this much opening, or putting an injection through and using an endoscope, not by direct hand also. In our direct hand only we shake. And through that little opening with using an endoscope, you are putting a needle through there, and then you are pushing a saline. And somewhere or other, these are therapeutic misadventure, you can say. Somewhere or other, the saline was little bit too much, or the speed was little bit too much, which have done some damage to the localized tissue, and that can cause the inflammation of the pancreas. So there can be ERCP induced pancreatitis as well. Okay, those who are undergoing ERCP, they have to be very careful about it, because it is one of the commonest complications of ERCP. Somebody who is going for ERCP to check for the, let's say, for the gallbladder tract. Okay, some stone is blocking over here, the patient is coming with obstructive jaundice like feature. Now you want to do ERCP to see if there is any stone or not, because as soon as you put the dye, I will go here, and after that it will not go, and you can see that there is something is blocked. You understand the stone is there most commonly. So that is why when you are doing the ERCP, you have to be cautious that you can inflame the pancreas as well, side by side. Okay, that is ERCP induced pancreatitis. And hypertriacylglyceridemia, that is a increased level of TGL, triglyceride level more than 1000. This is due to the deficiency of the enzyme lipoprotein lipase. The lipoprotein lipase it breaks the triglyceride and helps in the digestion of it. Now if this enzyme is only absent, then obviously it will not get digested. The level of it will keep on increasing, and it will eventually present like a pancreatitis case. Got it? Okay. Any doubt from this topic? Okay, so what are the key messages? Which region the pains are, whether it is referred to some other region or not, vomiting is there or not, bloating is there or not, on palpation the patient is complaining of pain or not. There is one more clinical feature. Whenever the patient is having pancreatitis, if you tell them to sit stooping forward, they will get relaxed, they will feel less pain. Why? You know, because whenever you are stooping forward, pancreas is a deeper structure. The front contents inside your abdomen, these are not coming in contact with the pancreas. Let's say this is a pancreas, and these are my contents inside my abdomen, which is touching the pancreas. Now if you are sitting like this, the contents are like this. Now you are feeling the pain because it is touching the inflamed pancreas. Now you are stooping forward, the pancreas is fixed with its location, but the anterior contents are coming little forward, so it's getting some gap. That time it is not touching the pancreas. That's why they try to tend to sit forward and bending forward, stooping forward, so that they get little relief from the pain. It is not the treatment, but they get little relief. That's why they tend to sit stooping forward. Okay, this is one clinical feature that can be mentioned in your question as well. That can guide you to probably most likely the patient is having pancreatitis. Because of that only the patient is stooping forward. If the patient is having gastritis and all these things, even if the patient tries to sit forward, there will not be any decrease of pain. Gastritis में ऐसा नहीं होता है. Or if there is any gastric ulcer में भी epigastric pain होता है. But in that case, if you stoop forward, your pain will not subside. It will be there. It will keep on be there. Okay, that's all. Now this topic is done. Oh yeah, and what are the key messages? What are the invasive tests, non-invasive tests? What are the causes of pancreatitis? And what are the enzymes that are increasing? Amylase and lipase. Most specific is the lipase. How many times it have to increase? 3 times. More than 3 times it have to increase. That's all. Khatam. Now the third case. Third case has already been taught to you people. I want discussion. Like these two cases I have been discussing. You people are listeners. Right now I want participation from you people. Okay. So this is the third case. Read the case. Let us together read the case. A 46-year-old lady is admitted with complaints of pain abdomen. First complaint is pain abdomen. Okay. Fine. Then in which side? Right upper quadrant. What is the right upper quadrant? Which one is the right upper quadrant? This area. This area is the right upper quadrant. Fine. Right sided upper quadrant. Okay. What happens over here? There is a significant, there is a sign which I tell you, that is the Murphy's sign. Murphy's sign. Now what is Murphy's sign? Murphy's sign is the patient is coming and telling you that some pain is happening over here, localized in the right upper quadrant. So you do what? You will tell the patient to lie down and you put your hand over here and tell the patient to take a deep breath. So what happens whenever we are taking a deep breath? All the abdominal contents go up. Okay, inside. Everything is going inside. Diaphragm is getting upwards. Everything is going inside. As soon as the patient is taking the deep breath, you put your hand as much as deep possible, like this much. Okay, and then tell the patient to release the breath. Okay, whenever the patient releases the breath, the abdomen will come back to its normal position, and the gallbladder, if there is any inflammation of the gallbladder, then the gallbladder will touch your tip of the fingers, and immediately the patient will feel such a pain, the patient will stop breathing and tell you move your hand. In medical term, we call it a catch of breath. Okay, the patient will stop breathing. The pain is so severe. That time the patient will stop breathing and tell you, sir, move your hand. I can't. It's so painful. That is known as Murphy's sign. So Murphy's sign is one thing that is significant of some pathology is there with the gallbladder. It can be stone, it can be inflammation of the gallbladder, it can be swelling of the gallbladder, any pathology with the gallbladder. When the gallbladder, normally the gallbladder is like this much, small. Okay, I'm just giving you an example. The gallbladder is like this much, which is carrying the bile. Okay, now gallbladder is inflamed because of any inflammation, because of stone, because of any other reason, or because of some collection which is filled up but not being able to come out, or because of obstructive jaundice. So bile will be collecting over there. The bile will get dilated like this much big now. Okay, the gallbladder is swollen up. Now whenever you are pressing, normally you cannot palpate the gallbladder. Now in me, in you, in any one of us, if we are doing this palpation, you cannot feel the gallbladder. But whenever this gallbladder is inflamed, that time if you palpate, if you press, then your fingers and the substructures will press on the gallbladder, and immediately the patient will feel the pain. Okay, that is what is the Murphy's sign. How you have to do? Tell the patient to take a deep breath. Whenever the patient is taking a deep breath, put your hand as much as possible. Once you put it, then after that you tell the patient to release the breath. Patient is releasing the breath, the structures will come up and hit your tip of the fingers. As soon as it hits, patient will feel so much pain, the patient will stop breathing and tell you move your hand. That is known as a catch of breath. That is the Murphy's sign. So if the Murphy's sign is positive, means something is definitely happening with the gallbladder. Okay. Now whatever it can happen. Now I don't know whatever is happening, I have to see the case first. Okay, so the patient is coming and telling you that there is a pain abdomen on the right upper quadrant. Okay, we got pain in the right upper quadrant. Okay, now comes vomiting for last 3 days, history of loss of appetite. Loss of appetite, patient is not feeling like eating. Okay, and weakness is there. Malaise, generalized body weakness, pain, and nausea means vomiting tendency. Okay, these are the symptoms. These are symptoms that can be there. Person to person it can vary. Somebody might be having nausea, somebody is not having nausea, somebody is having malaise, somebody is not having malaise. Not significant to the case, but can have. Okay, this can come, but not everybody will come with the presentation. But these pains and all, everything, these will be constant. Okay, there are some constant features and there are some variable symptoms, which in some patient there will be 1 symptom, some patient you will get 5 symptoms. Okay, that's how this is variable. Now she gives a history of yellowish discoloration of the eye. Another history, yellowish discoloration. Yeah, yellowish discoloration of eyes. Which part of the eyes? Sclera. Yeah, sclera. Okay, in case of medical examination, when we are checking the patient, we are checking the lower palpebral conjunctiva for hemoglobin, that is for anemia. Okay, don't mess it up. And the upper palpebral, no, we see upper bulbar conjunctiva. Okay, the lower palpebral conjunctiva we are seeing for anemia. Okay, and the upper bulbar conjunctiva we are seeing for jaundice. Okay, these are the two portions. One is the bulbar conjunctiva, another one is the palpebral conjunctiva. The whole sclera will be yellow, but we see on the bulbar conjunctiva. Okay, in this, when we are checking for the jaundice, it is also known as the icterus. Okay, so and this is pallor. Pallor means paleness. Okay, paleness means pallor. So pallor we are seeing in the lower palpebral conjunctiva. Icterus we are checking in the upper bulbar conjunctiva. Fine. So you can see the yellowish discoloration of the eyes and passing of high colored urine. So another history, urine color is high color. What does high color means? Dark yellow. Dark yellow, little dark yellow, we call it a high colored urine. And what is in case of hematuria, what kind of color you will get? It will not be black, it will be cola colored urine. Cola, like Coca-Cola, smoky cola colored urine. Okay, not black, you will not get black. Black you will get in alkaptonuria on prolonged standing. Okay, so you will get a this cola colored urine in case of hematuria. But here you are getting high colored urine. Okay, that is little darker yellow tone. Why? I will tell you everything. And clay colored stool. Stool is clay colored. Okay, if you follow the class, in class I have asked this thing, what kind of stool color will be? Clay color stool. And why? Because of the absence of stercobilin. Okay, so stercobilin is absent, something you can correlate already now. Stercobilin absent means urobilinogen is not there. Urobilinogen not there means bilirubin is not coming. Not coming means it's an obstructive jaundice. Something or other you can correlate already from the history. Now let us see what else they have given. There is no history of any fever, drug intake or alcoholism. Matlab, it's not nothing to related with alcohol, because alcohol can cause hepatitis, can lead to hepatic jaundice. There is no fever and no drug intake. Drugs can cause hemolytic jaundice as well. Some drugs can precipitate hemolytic jaundice, means breaking of the RBC. Okay, some drugs can affect the hepatic tissues as well, can cause hepatic jaundice. So these are not going towards that, they are indicating. So negative history is also important. Those history you are getting means there is something called, these are positive histories directing towards the case, and these are negative history that is ruling out other cases. Okay, you are ruling out other conditions, other jaundices. Now there is no history of fever, means there is no inflammation of the liver or gallbladder. It is not an inflammation of the gallbladder, because inflammation of the gallbladder can lead to the dilatation of the gallbladder and blockage of the bile duct. Okay, that can also lead to this kind of symptoms. So it is not that. Fine. Now on physical examination, the patient was found to be pale and undernourished. Why pale and undernourished? Undernourished because the bile enzymes are not coming, bile acids and bile salts are not coming in the digestion. So that is why the patient is taking food but not getting absorbed properly. It is coming out as it is. So that is why the patient is not getting nutrition. That is why undernourished. Okay. And then yellow discoloration of the skin, sclera and the palates are observed. Palate we less see, but we see morely on the skin and the sclera. That's all. You got it. Gallbladder is palpable. Gallbladder is dilated. So gallbladder dilated, obstruction, that is why biles are not coming out. That is why gallbladder is storing more than the bile as it would have stored. So that is why the gallbladder is also getting dilated and it is becoming palpable. So you will get the Murphy's sign as well. Palpate, the patient will complain of pain. Okay. Now liver was enlarged and tender. Why liver is enlarged? Because the bile salts are going back into the liver because of the obstruction. The liver is not supposed to store them. The liver is storing up to how much it is possible. The rest of the it's going giving to the blood circulation, systemic circulation. Now you are understanding everything, right? That is why the liver is enlarged. But there is no splenomegaly. Another negative history. Why splenomegaly is important? Splenomegaly means spleen should be enlarged. Hepatomegaly means liver is enlarged. Splenomegaly means spleen should be enlarged. If the spleen is not enlarged, means where the RBCs are getting killed? Spleen. If the spleen is working more, killing more and more RBCs, obviously the spleen will get enlarged. So this is ruling out a hemolytic jaundice as well. Understand? That is what the negative history is coming into play. If the splenomegaly is not there, means it is not hemolytic jaundice. If the splenomegaly, hepatomegaly both there, most likely it is going toward the hemolytic jaundice. Okay. Now every time this kind of histories might not be given to you, but if it is given, then it is helping you. The more history, the more help you are getting. Okay. If somebody is not mentioning the splenomegaly, then you have to come to the bilirubin. Okay. Now in the bilirubin picture, you can see one thing. The total bilirubin is 7.7. Oh yeah. Also, yeah.
Then again hemolytic.
It is not a hemolytic. That is what I am telling you. It's not a hemolytic. It's a negative history. We are ruling out hemolytic. If splenomegaly is not there, means definitely it is not hemolytic. If it is hemolytic, obviously the spleen is working more and more RBCs are getting dead. That is why splenomegaly should be there. They are saying there is no splenomegaly. Okay, so this is ruling out hemolytic. But clay colored, this is one thing you are getting already, but these are more helping towards to your destination, that yeah, this is obstructive only, this is not hemolytic, no way this can be hemolytic. More findings are there which will assist you. What? Total bilirubin is 7.7. What is normal? 0.8 to 1.2 or 0.2 to 1.2. This much is the normal. So 7.7 is high. You are already getting it high. Now indirect and direct. How much is indirect?
1.7.
1.7. How much is direct? 6.0. Both are high, but which one is more high? Direct is more high. Okay. In the exam, there were 2 students who could answer me this question. I was really happy with those 2 students. I am not going to mention the names, but there were only 2 students who could answer me this question. In case of hemolytic jaundice, indirect increases. Indirect bilirubin increases more. Direct also increases, but indirect increases more. And in case of obstructive jaundice, direct increases more. Why? Somebody.
In case of hemolytic, unconjugated bilirubin is being accumulated in the blood because of the RBC destruction or rupture, and unconjugated bilirubin cannot directly pass into the urine. It has to be passed. It is processed in the liver at first.
So in case of obstructive also it cannot pass.
Yes.
Then?
In liver, the unconjugated converts into conjugated.
How?
Uridine
glucuronide transferase. Now, yeah, you are close enough. He is close enough. Why? See in this image, the same image, the unconjugated one is getting converted into conjugated in the liver by the enzyme uridine glucuronide transferase, UGT. Okay. Now let's say right now I am having B positive blood group. Okay. Somebody transfused B negative blood group into my blood system. Many of my blood RBCs will get dead. Large amount of bilirubin will produce right now only because of the destruction of the RBCs. Fine. But do I have significant amount of UGT in my body stored already, because it's an enzyme which is stored in the liver? I have a limited amount of UGT in my body right now. So the amount of bilirubin that is produced, let's say that is 500 amount of bilirubin which is getting produced in my body. Just an example. And I have 100 amount of stored UGT in my liver right now. So the 100 UGT will be able to convert 500 unconjugated bilirubin into 100 conjugated bilirubin. And rest of the 400 will remain unconjugated only. Later on, gradually, when this storage will increase, this production will more increase. That time these will slowly get converted. But till that time, initially you will get more unconjugated increased. That is why in case of hemolytic, more indirect increases. Indirect means unconjugated. More of indirect increases in case of hemolytic jaundice. But in case of obstructive, what is happening? In case of obstructive, your bilirubin production is normal. So 100 bilirubin is producing, 100 UGT you also have. Everything is getting converted into conjugated. Okay, but after getting conjugated, it is not being able to come out because there is an obstruction. That is why in case of obstructive, direct one or the conjugated one increases more as compared to the indirect one. Indirect also increases. In all of the jaundice, everything will increase, but there is certain thing which will increase more. In case of hemolytic, indirect will increase more. In case of obstructive, direct will increase more, and this is the reason. And I was so happy that 2 students can relate it. When I told in my class, that time also I mentioned this. I did not mention about the hemolytic, but I mentioned about the direct one. Why the direct one increases in case of obstructive jaundice. That's all. So these are the things, these are the concepts that you have to understand. Why in case of obstructive jaundice the direct increases? Why in case of hemolytic jaundice the indirect increases? These are the applied questions. Okay, if you are going for Viva, teachers will first try to see whether you know the topic or not. The test, from the test steps and all, this vagara principle. These are very basic things. If you can't tell them, then you are failed already. Just don't even think about anything forward. Okay, if you tell the principles and all, then they will understand that yeah, you have studied. Then go little deep into the topic. What else do you know from the topic? These are the appliance of the test. Okay, somebody will not ask you, tell me the Ehrlich test. Nobody will ask you Ehrlich test. They will ask you if there is an absence of negative test of Ehrlich test, what conclusion can you come to? Obstructive jaundice. Why? Because the urobilin is absent, because of that the obstruction is there, that is why urobilin is not formed. That's all, like that. Okay. So coming over here, we are getting total bilirubin is 7.7, which is high. Now direct bilirubin is more. Again another hint of obstructive jaundice. You are getting pale colored stool, you are getting this, you are not getting splenomegaly. These are all directing you to obstructive jaundice. Okay, fine. Now there are some enzymes also, like see SGOT is increased, SGPT is increased, serum ALP is increased. These are also increased. But I have already diagnosed this case without even seeing all these findings only. Before only I had an option. After that, after seeing the bilirubin, now I am 99% sure it is obstructive. Few more findings have been given. Urine examination, the bile pigments, urobilinogen and bile salts. Now urobilinogen is negative. Understood? Bile salts are positive. You know, if there is an obstruction, bile salts will revert back and come to the urine. Fine. But bile pigments, how come these are positive? Bile pigments should be negative, right? Bile pigments are not water soluble. So how come this is positive? Any ideas? See, what I told you that time, initially that was partially true. If you have noticed, bile pigments are not soluble, right? But bile pigments are not soluble up to an extent. When they are unconjugated, they are not soluble. Once they become conjugated, they are soluble. So in the liver, when they are becoming conjugated and they are not being able to come out, some of it are coming into the systemic circulation. Got it? When they are coming into the systemic circulation, they can come into the urine as well. Because after getting conjugated, they are becoming water soluble. Before that, they are water insoluble and they cannot come to the circulation. Got it? Yeah. Fine. Now, over here, that is why the bile pigments are present, urobilinogens are completely absent, bile salts are positive. Got it? Now, attending physician makes the diagnosis of obstructive jaundice. Why? Because of all these causes. We had that what we have discussed till now. All these causes will lead to the diagnosis of the obstructive jaundice. And the further workup is planned to diagnose the cause of obstructive jaundice. What is the cause? That you can do with the ERCP and all these things. You can find out why the obstruction is there. Some questions. Diagnose the case and explain why. Do you need any other explanation for diagnosing? Enzymes you have seen, that is bilirubin is raised. Other than that, liver enzymes like AST, SGOT, SGPT, ALP, these are also raised. Okay, these will also help you. But the first and foremost thing are those things. Bilirubin. First you have to see the bilirubin, then you have to see the urinary findings if it is given. Not necessary every time you will get all these things. And then the history of the patient. You have to get the history. Yesterday somebody asked me, sir, how will I understand about hemolytic jaundice? Definitely hemolytic jaundice will not have the same picture. There will be some history where the patient will be losing blood. Some RBCs are getting destroyed. Blood transfusion history, accident history, some history, any kind of history. Some kind of history would be there where the patient is losing the blood. When the patient is losing blood, the RBCs are getting destroyed. If the RBCs are getting destroyed, that can lead to hemolytic jaundice. And more importantly, the bilirubin picture will be indirect, will be more high. Got it? So that is kind of differentiating between the obstructive and the hemolytic. In case of hepatic, both the direct and indirect can increase. Why? Because the liver cannot reuptake. The enterohepatic circulation, that is the bilirubin is undergoing, it's coming back to the liver. Then the hepatocyte should be able to reabsorb, but the hepatocytes are not being able to reabsorb. That's why it is coming into the circulation more and more. Okay? And that is why in case of hepatic jaundice, direct, indirect, all increases more or less. Okay? Now, in case of hepatic jaundice also the history will be different. Somebody who is alcoholic, chronic alcoholic, because of that the liver cells are damaged. Somebody who got hepatitis, some virus-borne infection. Somebody who got some trauma history to the liver, because of that the liver got injured. Like that. Somebody who had a history of transplant and after that the transplantation failed. The transplant failed. The donor failed. The receiver rejected the donor. Okay, so these are the some kind of history, something or other history which is related to the liver you will get, something or history which is related to the blood, that is there, blood loss is there, that is hemolytic jaundice, something or other related to this clay colored stool, this obstruction is there, pain is there, jaundice like feature is coming up. So these would be the features of the obstructive jaundice. Okay, now explain the bilirubin metabolism. The explained bilirubin metabolism is still there. You all have written it down, I hope so. Okay, if not, still follow it once. In the reticular endothelial cell, RBC is getting broken down into heme. There is a short of the step, that is the RBC first breaks down and forms the hemoglobin. From hemoglobin you are getting heme and globin goes back, heme comes down, from heme you are getting first biliverdin, then bilirubin. Biliverdin you are getting via heme oxygenase, and then biliverdin to bilirubin via the biliverdin reductase. You are getting bilirubin, that is the unconjugated bilirubin. Now this unconjugated bilirubin cannot move. Okay, so it binds with the albumin and it remains still unconjugated bilirubin only, but it can move now. Okay, this unconjugated or the indirect bilirubin. Now this, after it gets mobile, through the bloodstream it goes to the liver. Once it goes to the liver, there is an enzyme in the liver, that is a UGT, uridine glucuronide transferase, which is converting the unconjugated bilirubin into conjugated bilirubin, that is the direct bilirubin. Once the direct bilirubin is formed, it will come into the gut via the bile duct for the digestion of the fats and the other nutrients. When it comes in the gut bacteria will convert into urobilinogen. The urobilinogen have three fates, that is 80% is coming into the feces as stercobilin, 2% is coming into the urine as urobilin, and rest of the 18% is through the enterohepatic circulation coming back into the liver. Now if there is a liver damage, this part is defective. This reabsorption is not happening, because of that the circulating bilirubin is more. Okay. In case of hemolytic, over here there is a defect. In case of obstructive, over here there is a defect. So just write this thing in a paper, post it in your wall. यहाँ पे 2 क्रॉस लगा दो, यहाँ पे लिख दो हेपाटिक जॉन्डिस, यहाँ पे 2 क्रॉस लगा दो, लिख दो ऑब्स्ट्रक्टिव जॉन्डिस, यहाँ पे एक राउंड मार दो और यहाँ पे लिख दो हेमोलाइटिक जॉन्डिस. These things will be crystal clear to you. Okay, never ever by heart these kind of things, never ever. Understand and then finish the topic. खत्म. By heart करना होगा तो by heart करने का बहुत सारी चीज़ें हैं. ठीक है. What are the causes of this obstruction? Can be GB stone, gallbladder stone. Because of gallbladder stone, there can be obstruction. It cannot come out. Malignancy of the head of the pancreas. Malignancy means cancer. If the head of the pancreas is having cancer tissues, I have explained in my classes as well. If there is a cancer tissue, obviously this bile duct will get obstructed. It cannot come out. Same. Stricture of the sphincter of Oddi. What is sphincter of Oddi? Can anybody tell me? Sphincter of Oddi. In the pancreas there is an opening duct, okay, that is known as the sphincter of Oddi or Oddi, whatever you say. There is a stricture, means it's the narrowing. Stricture means closure, narrowing. Like this is a normal tube. Okay, now if the tube is like this is known as stricture. Okay, so if there is an opening of the pancreatic duct as well as the bile duct and there is a stricture, that means there is a narrowing. And that opening is known as the sphincter of Oddi. The stricture of the sphincter of Oddi means it is like this. Okay, it should be like this, like a fish mouth. Okay, it is not like this anymore, it is narrowed down. So over there, it will not be able to come out. That is what is written over here. Okay, now what is the reason of the clay colored stool in obstructive jaundice? Absence of urobilinogen. If there is absence of urobilinogen, no stercobilin, that is why the clay colored stool. Khatam. Why direct bilirubin causes more in obstructive jaundice? Why direct bilirubin is more in obstructive jaundice?
Because the flow back, there is backflow.
No, direct bilirubin I am saying. Direct bilirubin.
Converts into direct.
It converts into direct bilirubin, but after that it cannot come down. After that it cannot come down. No black flow. Backflow is for bile salts. Don't confuse. Backflow is because of bile salts. If they are mentioning about direct bilirubin, again see over here, direct bilirubin. They are forming direct bilirubin, but it cannot come back. It cannot come down because of the obstruction. If it cannot come down, obviously it will increase, right? Because from the indirect it is getting converted into direct, but after that no outcome from there. No outcome from there. So no fate only. So that is why in case of the direct bilirubin increases more in case of obstructive jaundice. Same question can be asked in case of hemolytic jaundice, why the indirect increases. The same way, not if sufficient enzymes, insufficiency of the UGT, which can convert all of the bilirubin into direct. That's why the more amount of indirect bilirubin increases. Fine. Now what test is done to assess the urobilinogen in urine? Earliest test. Simple. What are the various causes of obstructive jaundice? Just now I have mentioned. Gallbladder stone, stricture, or malignancy of the pancreas, any cancer. That's all. Khatam. Okay. That's all. These are the 3 cases. Okay. Any doubts from the 3 cases? See over here. There is one more case given. Patient comes in medicine OPD with fatigue, jaundice and dark colored urine for 1 week. Now the history is so different. Fatigue, patient is having weakness. There can be multiple reasons of weakness. Jaundice, okay, bilirubin is raised, and dark colored urine. Dark colored urine means cola colored urine. Hematuria is there. Patient is bleeding. Something is happening in the patient. Because of that, if the hemoglobin is less, that is why the patient is feeling weak, fatigue. Okay, and that explains the jaundice as well. That is how the history will be different. No way somebody will be giving you a history of obstructive jaundice and asking you hemolytic jaundice. There is no way of that. Okay. Now has no significant past medical history. So पहले का कोई history नहीं है. Upon physical examination, it showed a pale conjunctiva. The conjunctiva is pale. That is significant of anemia. And icteric sclera. The icterus is also there. Pallor is also there. Both are there. And mild splenomegaly. Now you are getting splenomegaly. Why splenomegaly? Because more and more RBCs are getting destroyed. So that is a significant history of hemolytic. Now laboratory findings, you have already came to the conclusion. See, this is the fun of medicine. When you know the reason behind it, you can come to the conclusion only by listening to the patient's history. You don't have to always depend on the lab reports, because in recent trends what people do is like, people are so fond of doing lab reports. Do the lab reports, then do the treatments. Why? Before that, people used to treat it only by listening to the complaints. So try to understand it, you will get the fun of it. Lab reports are confirmatory to tell you that yeah, you are right. Before that, you should have your diagnosis inside your head, like yeah, this is how this is going, this could be the diagnosis. And your lab reports, as soon as it comes in your hand, you see that whatever you are thinking, lab reports are matching with it, you will get the immense pleasure. The happiness is beyond this thing. Okay, that whatever you are thinking, the lab reports are coming according to it. Okay. In the lab finding, what you are getting, hemoglobin is less. So bleeding is there. Because of that, the blood is there in the urine. Mean corpuscular volume is 89. Now what do you understand by MCV? MCV has been covered in your physiology, right? What is MCV? What does indicate? Full form of MCV? Mean corpuscular volume. If you try to understand in normal, basic, pati bangla jodi bujhte chesta koro, that is MCV means the size of the RBC. If it is normal, large or small, that's all. Okay, what is the normal size? 80 to 100 approximately. Some book have altered values, 80 to 100 or 102, something like that. Something is like that is there. So if it is less than 80 means microcytic. So something is wrong with the RBC. Most common cause of microcytic RBC getting is iron deficiency anemia. Okay. If it is more than 102, it is macrocytic. More common cause is the megaloblastic anemia, folic acid deficiency, vitamin B12 deficiency, that can lead to this pernicious anemia as well. Yeah, pernicious anemia is combination of megaloblastic as well as normal. Okay, now these are there, and over here this is 89, means it is normal. There is no defect in the RBC itself. Okay, formation में कोई defect नहीं है, बाकी सिस्टम में कोई डिफेक्ट है जिसके वजह से ब्लीडिंग हो रहा है. Now reticulocyte count is 8%, which is elevated. Normal reticulocyte count is 1 to 3%. 1 to 3%. Okay. Books can differ, but more or less 1 to 3%. If it is more than 3%, that is also abnormal. Less than 1%, that is also abnormal. Okay. Not going into the types. It will be very long. Now platelets and white blood cells are normal. So peripheral blood smear, you have seen some cystocytes, some spherocytes, and polychromasia. Cystocytes, spherocytes, it's better if you go along with the physiology only. Cystocytes are seasons, have some this kind of crescent shape blood you can get. There are multiple diseases: thalassemia, beta thalassemia, sickle cell disease. Over there you can get this kind of. I am not going into it. Okay, so. And there is one enzyme, this is my part, lactate dehydrogenase. LDH is high, multifolds. Normal is 135 to 225, it is 850. Multifolds high in LDH. Why? Because of the destruction of the RBCs, LDH is increasing. Fine. Now indirect bilirubin is high, again see over here, 4.5. Okay, that time it was 1.7 and other one was 6. Over here this is itself only 4.5. Okay, so that is how you will come to the conclusion. So these are my biochemistry portions. One is LDH is high, indirect bilirubin is high. Now haptoglobin, undetectable, Coombs test, you don't have to go into all these things. Coombs test and all. Coombs test is you have to check if there is a RH factor is playing a role or not. Okay, direct Coombs test, indirect Coombs tests are there. It's better if you study it in physiology or pathology. Okay, means somebody is having one blood transfusion, after that you are getting some blood is getting lysed, you are doing the Coombs test immediately. If it is coming positive, means there was a RH mismatch, because of that only the blood is getting lysed. Okay, that is how it is helpful, not going in deep into that, and that is why we are doing the test. Better you study from that subjects only. Now other tests, serum creatinine normal, urine analysis are hemoglobinuria without RBCs. Okay, so hemoglobin is coming in the urine, but RBCs are not there, means RBCs are getting lysed beforehand only. Where they are getting lysed? In the spleen. Okay, over there they are getting lysed. It could be any disease in which the RBCs are getting lysed. Yeah, so urine analysis shows hemoglobinuria. So hemoglobins are coming because the RBCs are getting broken down beforehand only in the spleen. Because of that the splenomegaly is also there, and the broken down product, the hemoglobin is coming in the urine. And in the system the hemoglobin will get metabolized. How? The hemoglobin will break down into heme and globin, and so bilirubin is formed. Clear? So that is how the history will be different. In case of obstructive jaundice the history was different. In case of hemolytic jaundice the history was different. Like that. Okay, so don't confuse with the histories. Okay, any doubt? Nothing, right?